It is a great honor for me to do a second session and webinar on Spincare. It is a great honor to see my friend again, Professor Dr. Jan Plock, which is from Switzerland. He is a plastic surgeon, as I am, doing aesthetics and reconstructive. He was studying in Bavaria, Würzburg, and I hope I don't miss all the names there, in Bern and in Zurich Hospital and University. He also did a fellow and graduated in Pennsylvania, Pittsburgh, USA, with Peter Rubin. He maintains a lot of international connection, including with me, which is great. I think he's doing a great work because I've seen some of his experience showing it to me in the era before Corona. Today, he's the chief of the division of plastic surgery and hand surgery in Canton Hospital, Aarau in Switzerland. He's very, very respected physician and leading in Switzerland and Europe as a great scientist that experiments and looking for new technologies. I've seen other stuff that Jan makes. He has a lot of courage doing and trying new stuff as I'm trying to do. He has already 2 years of experience with Spincare, and I guess it's an honor for us to see and to have him to share with us all his experience. So Jan, it's my pleasure to give you the stage.
Thank you very much, Joseph, for your very kind introduction. It has been a pleasure to collaborate with you, and I also want to thank Chen Barak and Gary Zagev to organize this webinar and share our experience. If you're working with innovative technology, I think it's very important to share the experience, how you use it, how you start using it. And with a new product, this can really be challenging to bring it to the market from the perspective of the company, but also from the clinician's perspective to use something new in your setting, to make modifications that the new stuff fits into your setting. And I want to speak a little bit about our experience, how we did that over the last couple of years. I came to know Chen Barak and the company in about, I think it was 2017, and there were only a few prototypes of Spincare available all over Europe. And that was when we started, actually. It already had a CE label, so safety was guaranteed from the company's side. We were allowed to use it. There were no safety issues. This was all solved. But if you start something new with a few tools spread over Europe, and you only have the experience of Joseph Haik, who did use the Spincare in Israel before, I think this is quite a challenge. I want to start and acknowledge the University Hospital in Zurich, where I have been proud to work for the last 10 years. I switched positions last autumn, but I was director of the Burn Center for the last almost 6 years at the University Hospital before. And this is really a temple of innovation, a temple of research and highly specialized medical care. It has one of 2 burn centers, and this is where we started to use Spincare. And this is one of the first pictures I actually saw, and it's quite interesting, and it really interested me a lot to see technology utilizing a system that is looking like a gun and highly sophisticated nanotechnology with electrospinning. We have been researching electrospinning before and nanotechnology before, for example, in tissue engineering stuff and to produce dressings and different things, surfaces, for example. But it was completely new to me being able to use electrospinning technology in a patient. This is the basic technology behind Spincare. It is electrospinning nanotechnology, and what you actually do is, with this gun, you produce a nanofibrous matrix. On the right side, you see the matrix, this network of nanofibers in comparison to a human hair. And on the left side, you actually see how similar it is to extracellular matrix. An extracellular matrix is extremely important for tissue regeneration. It is important in research for tissue engineering and a lot of regenerative processes that happen in the human body. And if you look on the right side, this is completely artificial. This is the result of the Spincare technology actually when you use it, and this is what you get out of it. So that was quite interesting for me to see and understand the technology behind Spincare first. If you use the Spincare system and create such a matrix on your skin, it immediately becomes attached, and only if you lift it up and keep it uplifted, it looks like a very dense spider web. With the scientific background of the matrix and the electrospinning of the matrix, it is an excellent medium for tissue integration. If you have such a network, cells can migrate, it can get vascularized, cells can migrate along the network and the matrix. It has a reduced potential for infection because it's very dense on the surface. Theoretically, it is improving wound healing. You could even integrate drugs or use it for medical application, and it's permeable. So you get a regulation of the wound fluids, of the humidity of the wound, and oxygen can transfer and pass the membrane you are creating. It also is very thin if you spin these fibers. Of course, if you spin for a longer time, it becomes more dense. If you just spin very shortly, you just get a very thin layer of this matrix on top of every surface you spin on. On the left side, you see technology that is normally in use for electrospinning. These are huge machines in huge labs or in companies. And well, this is now a complete downsizing of the technology into a gun system. On the very right side, you see how this stream coming out of the gun on the tip of the gun is creating these polymeric nanofibers, and how the webbing actually happens in the stream. And the technology is pictured in the middle here. You have a syringe with the pump and polymer solution on the tip of the syringe. You apply a high voltage, and then you have this electrospinning jet, and you really create these fibers, nanofibers on your surface. Very simple. Well, the technology itself is fascinating, but the principle is quite simple. Now, this is what we got from the company. We got a gun, and we got a kit with the fluid called the Spincare kit. And you can actually put the Spincare kit into the gun like ammunition. And well, I'll show you a video how we do that just in a minute. And it's creating a biomaterial. My interpretation from the very beginning was that we create a scaffold that by using it, you just get a scaffold for tissue regeneration. And it is a thin and pliable wound cover. and would be ideal for conservative burn wound healing. Protecting the wound, managing the wound, the moisture of the wounds, and actually promoting wound healing. I will talk a bit about our patients, how we started. And well, if you get a new tool in burn surgery, one of the first things you want to manage is a donor site, split thickness donor sites. So the residents actually not very nicely, as you can see here, took skin grafts in a very young female patient. Doesn't look very nice. We applied the Spincare technology, as you can see on the second picture. You have to use an electrode connected to the patient close to the wound bed. This is the white line you can see. Just place it on the skin with an EKG electrode plaster, very simple. And then the wound is covered. And you also observe on the right side that immediately we made our first mistakes. We covered the wound, we used petroleum jelly gauze. It was looking awful on the next day. Nobody knew what to do. And if you follow it up a bit after 8 days, well, we got a very nice healing. Doesn't look so nice, but it healed anyways. So I was checking with Chen Barak after that, asking, and she said, well, of course, you shouldn't use additional dressings. And if you do, at least use Mepithel. And this is how we moved on from our first patient. There was no downside from this initial dressing, but there was no advantage so far as well. In the second patient, who was male, 48 years, again, we applied it on the donor side. And this time, we didn't apply any superficial dressing. You see this white colorish matrix on top of the wound bed. It becomes immediately transparent where the wound is moist. But if the edges are becoming whitish, you already know that you applied enough material on top of the wound. And what happens during the next couple of days is that it's kind of drying out. And what we learned over time is that you can, after about 20 to 30 minutes, it's really attached to the wound bed. It's more or less integrated, an integrated matrix in the wound bed. And you can start doing whatever you want. You need no dressing on top. So you can even, if it starts shrinking and the wound is starting to shrink and drying out, you can start creaming. You can start having showers after a couple of days. It doesn't matter. It's quite resistant, and you can't, like, well, of course you can scrape it off, but that would be kind of a surgical intervention. But you can't really peel it off. So next step for us was to use it in a real burn patient and to apply it in a superficial burn. And as you all know, these superficial burns are quite painful. Nobody really knows what to put on top. Of course, we all know that you can treat them conservatively. You don't have to do anything special. Some of us use creams, ointments, or silicone layers on top, non-adherent dressings. And what we did here on day 0, all of our patients get really a sterile debridement. We let it like clean for a day with Mepithel, and then we applied the Spincare. Again, you see on the bottom of the picture these electrode plasters where you can fix the electrode for the Spincare system, and then you apply the matrix. And after 7 days, this is dry, almost healed. No additional dressing was placed, And well, when it becomes so dry, the patient reports some itching, but then you can start using your ointments. In the next patient, well, we went one step further, and one step further was using it in a real burn injury that probably cannot heal by itself or takes longer time. And this is quite an interesting case because we mixed innovative procedures and innovative technology. So in this patient with a burn injury on the hand, you see these whitish areas, 2B areas, mid-dermal to deep dermal, and we applied Nexobrid, enzymatic debridement of burn wounds on day 0. In the middle picture, you see the immediate picture. You get these bleeding spots in the wound bed. It's quite moist after that. And we usually apply a post-soaking period for at least 8 hours, in many cases overnight. And after removing these post-soaking dressings, on the next day, you see that the hand is less swollen, it's becoming drier. And then the question is, what do you put on top next? And if you use heavy dressing and creams, you may also use a splint or something to avoid the pain and keep it stable. But what we did here is actually using the Spincare. See that we do this all under sterile conditions. You see the webbing between the fingers, and you can just cut it with scissors, and then it gets attached to the wound edges. And from day 3 on, we allowed the patient for early mobilization. So no skin grafting, nothing else, conservative protocol, and early mobilization of the hand without additional dressings. A couple of days later, somebody applied a Mephifill. Finally, you see all these imprints here on the back of the hand, but it was dry. The matrix was still in place after a week, and it starts to heal. We start using ointments, so Pepperthin ointment actually. And what looks like an additional eschar is actually the matrix peeling off. It's not a burn eschar as we used to see. It's more a pseudo eschar, and it's coming off. And the hand, you see how moist it is when you cream every day, is healed conservatively after 21 days. And there's no need to use extra dressings. Some of our junior residents actually still use Mephifill, but it's not necessary. You can leave the hand open and just cream as often as you like. And the eschar is coming off when it's healed. So as an interim result, we thought that Spincare is an appropriate dressing at least. It's advanced technology, you can apply it easily. It's providing a matrix, a 3D matrix to improve wound healing. We can mobilize our patients earlier, that was our impression. It's kind of drying out, and patients observed some tension in the wound bed when it's drying out, so you can start creaming and putting ointments, whatever you prefer, to put on top of your dry wounds. So we thought if we can use this technology in a 3D fashion, why shouldn't we move on to use more sophisticated burn injuries that are difficult to dress, that are challenging to treat, and that are really challenging with regards to an aesthetic outcome? Most of you who are treating burn injuries to the face still, know the problem of dressings in the face. Patients look like mummies, and if you look into the mirror, patients are frightened and don't recognize themselves. The family doesn't know who is in front of them. So this is really the challenge with facial injuries. And in Zurich, we have been treating facial injuries with an open wound in treatment. We used steroid creams very early on. We had a spray and a foam. So it was kind of an exposition treatment, but there was no true wound cover. And with the Spincare, we thought we had found an ideal matrix, an ideal technology to cover our wounds, even if we apply a steroid foam in advance, like prednisolone spray or prednisolone foam. I hope this video works. I want to thank Dr. Kim, who was one of our consultants, and it's his video. He produced it and he shared it with me when he was using the Spincare system, and this is to teach our junior faculty and residents how to use it. I want to show the video. This is how you use this syringe. Well, let me go back. The syringe is on the right, then you have kind of a blunt needle tip. You open the gun, you place the syringe in the system, just fitting in, and then you're ready to apply. And you see this white, very thin web that is coming on top of the wound. That's just sufficient. And sometimes it's really difficult, like in this patient, older patient. You won't have appropriate dressings around the eyes. The patient is tubed. You're an anesthesiologist, really want to fix the tube. You have a gastric probe through the nose and all this kind of tubes and lines. I want to show it again very briefly. Loading of the cartridge, placing the blunt needle. The needle itself is actually sterile. Remove it, put it in the gun, and the rest is done like in any other gun. There's a very thin, almost invisible stream. The red dot actually saw as a laser pointer to keep the ideal distance to the patient. It was very brief. Don't know if you have seen it. Trying to start again. Oh, that was too late. Here's the red dot. You see, just to know where your distance is. And you see the whitish matrix that you produce on the skin. This is the follow-up of the very same patient. On the left, you see initial debridement. On the right, you see what it looked like after applying the Spincare. Of course, the face is swollen a bit. After 3 days, swelling is gone. The beard is actually growing back. The patient is on the regular ward already. It's becoming dry. We start our ointments. After a month, everything is completely healed. It has peeled off after a week or so with the cream. This patient was under the shower after 5 days. And you see on the very right picture, the cream. The patient is really in need of ointments and creaming the face, but it's very cool, a very good outcome. Next patient is younger, a very young patient, but you see the follow-up. After 9 days, it's completely healed. On the left side, you would think there might be even some 2B areas, a swollen face, and on the middle face and the right face, you see the swelling is completely vanished and the healing is complete. There is a bit of a redness like after any burn injury, but the follow-up is scarless and a very good healing in the face. And he had almost no pain actually, could move on early. He was released after a couple of days. And this is what we observe in the face on a regular basis. 2 long-term outcomes just to share. So no scars, very regular a good outcome after two second-degree facial burns, an older patient and a very young patient with a long-term follow-up. So also during the long-term follow-up, there is no special a negative outcome or anything else. It's just a healed wound, burned wound. And we didn't observe too much of redness in these patients compared to deeper injuries. We didn't treat third-degree facial burns so far. For us, it was important to cover the wounds and regulate and control the wound fluids, which we could perfectly do with the Spincare system. So next, we started with chronic wounds because, well, they're frequently infected. And if you're thinking about the matrix that the Spincare system provides, you would think that this is an ideal wound cover. It controls the fluids, the moisture of the wound bed. It controls well, cellular ingrowth. It might promote even cellular ingrowth. And this chronic wound was actually open, as you can see on the left side, with the severe skin damage for almost 2 years. And we applied the Spincare because it was just a test. We had nothing else to do. He was in our outpatient clinic for chronic wounds, and we applied the Spincare system just once. We still used a dressing on top. You know, this patient was ambulating, he was outside. We didn't quite know how his compliance was. As you can see on the right, this is day 5. And you already have the ideas that something is healing here. I show you the follow-up. This is day 10. It's almost healed. After 2 weeks, it is almost completely healed. And this was really our wow effect. I wouldn't speak about miracles. I think there's technology behind. We were able to keep the wound clean. There was no infection. But for this specific wound, which was complicated, difficult to treat, it was open for a very long time. It obviously was a very good treatment that was capable of letting this wound heal. And you see there are vascular problems in this leg. You see the skin tone changes. But for this patient, it worked out perfectly well. So in summary, we have seen an innovative technology. In my experience, we have used it now for almost 3 years. There is a multitude of indications. It provides aesthetic and functional outcome. You can go for early mobilization with a very thin dressing. There is a learning curve, how to use the system and apply it for your patients. There's the possibility to use skincare products on top, and it's actually safe and easy to use. And for the residents, it's fun to use innovative tools in your department, to learn by doing innovative procedures, to learn new stuff, and create the future with these innovations. And it's their own future that they create. And I think this is a big success if you can implement innovative technology in your department and in your clinic. It's a success for everybody. The next step for myself is actually to implement the technology in a tertiary emergency center, like the Cantonal Hospital here in Aarau. There is no burn center. We have 2 national burn centers. One is where I've been working before in Zurich. The other one is in Lausanne in Switzerland. We only get minor burn injuries, but we have a frequent number of pediatric burns and scald injuries. And of course, there it would be an ideal dressing. You can treat the patients and the kids on an outpatient basis. And of course, I want to use it again and continue using it for adult facial and hand burns because it's so easy to apply in a 3D fashion. You achieve early mobilization and aftercare. Patients can go to occupational therapy after that. They can leave the hospital even if it's a bigger facial burn injury, if it's superficial. You just apply the Spincare and the patient can be dismissed on the next day. I want to thank you very much for your attention. I'm open for discussion, and I think there are a lot of questions already in the chat. Perhaps, Chen, if you want to moderate, or is Joseph moderating the questions?
I will leave it to Chen because she sees all the platform and all the participants, so she might guide it through. Thank you.
Very good, thank you.
So I'll just read the questions for you. The first question is there any restriction on the type of burn, chemical or thermal?
We haven't tried on chemical burns, actually. I think it depends if you have a 3rd-degree chemical or thermal injury. I think there's a need to remove the eschar. If you have a 2nd-degree superficial burn, it's an ideal dressing, but honestly, I haven't tried in chemical burns yet.
Okay. Can it be used with hyperbarics?
Hyperbaric oxygen therapy, I have no experience personally because there is no hyperbaric oxygen therapy available in Switzerland. But I think there is no limitation to that because it's a systemic treatment, topical and systemic. And I wouldn't assume that there is a limitation to it.
I tend to agree with you. What about the bacteria contained in the wound at the time of application?
You have to clean up your wound first. As you saw, we debride our wounds and apply it in a sterile fashion. I think this is quite important. We haven't used it in contaminated wounds.
The next 2 questions has to do with the RECELL system. And the question is, how do we compare the 2 products, basically?
How to compare to other products? Is that the question?
Yeah, the RECELL. I think the RECELL system.
The RECELL system. I think it's not a direct comparison. If you could use the Spincare system on top of the RECELL system to keep the wound bed after applying the cells to keep it clean. I think that would actually be an ideal dressing on top of RECELL. The RECELL system is promoting wound healing by applying cells to achieve faster healing. And the Spincare system, at least theoretically, would add the matrix to that. But I think it's not a direct comparison, one or the other.
Yes, potentially complementary at this stage. How many applications does the kit last?
We only used 1 kit per patient. Perhaps you can help me out with that, what the area would be you can use it on, 1/2 square meter or a square meter?
So I would just say that this is a sterile, the ampoule is sterile. It's intended for single patient, single use. So you cannot move it between patients. And the area of the amount of solution that we provide in the ampoule can cover an area of about 250 centimeters square. Okay. Is it effective for all types of burns? I think you've touched it a little bit, but maybe
I
a little
think
bit
the
of
ideal indication is superficial burns. In first-degree burns, you don't need anything. And in third-degree burns, I believe, I'm convinced you have to remove the eschar and surgery should be done first.
right. I can just add that in the other centers, same as you, they have used it on second-degree superficial to intermediate burns.
Yeah.
What is the burn and what if the burn layer get and layer get wet?
If I think the question addresses the condition of the wound bed, if it's very moist or not. If it's too wet, there is a risk that the web is actually not really attaching to the wound bed. This is one of the reasons why we were waiting in some patients at least 24 hours until we applied it, like in the enzymatically debrided wound. These are very moist, and we wait like at least for the next day to apply the Spincare system. Normally, if you have a 2A burn and you clean it up, these are not so moist and you can apply it easily immediately.
Okay, so the next one is really, again, how do you manage the exudate in the first 2-3 days, especially if the donor site is somewhere where cloth might be worn?
Again, if the exudate produces a lot of volume, I think you can use a cover dressing, ideally Mepithel and gauze. In our experience, it is not necessary. If you leave it open, evaporation is just enough to let it dry out, and we didn't experience any problems with the exudate in our cases.
Right. Is it enough just one application in a patient with second A facial burn,
Yes.
or more than one application?
No, just one application. Clean up the wound. When everything is clean, you apply the Spincare. You let it attach to the wound bed, which lasts about 20 minutes, and then you just leave it open. That's enough.
Okay. How long does it take to cover an adult face on average?
3 minutes, not more. You need some technical preparation, you know, with the EKJ line, but that's it. Prepare the gun, have everything ready for the application, and then really it's not more than 3 minutes.
So was the leg ulcer the only chronic wound you treated?
We started treating that, but I can't report on like a multitude of cases. But this is something we are very interested in to look into.
Regarding the VAC system, would this be used together or not recommended?
I have no experience. I would think that would not be recommendable to use that in addition, because the VAC is a very, well, has large porosis, and this is the complete opposite of what you try to achieve with the Spincare system, where you have a nanotechnology with a very fine and delicate matrix. So of course you can try that, but in my opinion, it's probably just not necessary. But I've never thought about that.
How do you think it might compare to BioBrain for superficial burns?
Less expensive, number one, and second, probably comparable or superior.
Have you used it over dermal matrix, collagen, elastin template? Would you recommend to use over it or for dressing?
I haven't done that actually. For dermal matrices, I actually frequently use a wax system. I don't see a huge advantage. It's not like with the dermal matrices, you really want to have them attached to the wound bed and to fit them in nicely and get as much contact with the wound bed as possible. And this is not what the system is for. The Spincare system is actually like folding in and matching into the niches of the wound bed very nicely when you spin it directly. So it's completely different to what you try to achieve with the dermal matrix, in my opinion. And it's not a skin replacement.
Can you apply Spincare to the abrasion or bruise from accident?
That will probably be possible if there is not too much of exudate, yes. This is, for example, what you have with skin graft donor-sites. They have kind of an exudate, but if the bleeding has stopped, you can apply the Spincare system after that. Might be comparable to dermabrasion.
In necrosis caused by uronic acid treatments after vessel embolization, can you use that?
I don't know. I have no experience actually with that. But in a necrotic wound, I wouldn't see the advantage.
Should we use all tube for application?
For me, it didn't get that right.
Should we use all the content of the ampoule in one application?
That's not necessary. You just use as much as you need to have a thin layer. When it's becoming whitish or transparent, it's already enough, and you don't have to use it up.
Okay. Okay. What about using the Spincare device on diabetic neuropathic wounds, venostasis wounds?
If the wound is clean, again, this is a topic of chronic wounds. If the wound is clean and there is a healing tendency, you have no contamination with bacteria and there is no necrosis, I think it's a possibility. The problem really is the infection. If there's a biofilm or ongoing infection, I think it's not recommendable to cover it with an almost occlusive matrix. It's just managing the humidity or moisture.
Okay. Is it better than the polymedics dressing?
I think it's comparable actually. There is a difference that the polymedics is kind of a sheet. And there, for me personally, there's a bit of a different indication for that. With the Spincare, I have the advantage to use it in a 3D fashion. For surfaces, you can use the polymedics material as well, and you can cover quickly large areas. If you have the time, you can use the Spincare as well. So it's a similar indication. For 3D, personally, I would prefer Spincare, but there is, well, could be comparable, yes.
Okay, what creaming do you suggest for post burns?
We use pepperthin. Yeah, that's actually what we use quite frequently, or a lipolosho. with containing urea. It's very helpful against the itchiness if you have urea in your ointment or cream.
So basically, the next question is regarding patients suffering from itching. So I think it's probably the answer, right? Using cream moisteners.
Yeah.
Right. What else? There keep coming here. So there is a question here. It's actually interesting. Can it be used as a first aid dressing, like in ambulance, or until the patient reaches the hospital? What do you think?
I think it doesn't make sense to use it there because you would have to remove for proper wound assessment. It doesn't, at least in my experience, it doesn't stop bleeding, for example. And if your wound is contaminated or dirty, if you have an scar on top, if there is smoke or charcoal on top of your wound bed, I don't think it makes sense to use it during transport. There's no advantage of such sophisticated technology to be used during transfer. But you could immediately use it in the emergency room after cleaning the wound. Yeah.
So can you repeat the indications of the applications of the Spincare?
Yeah. For me, it's superficial burn injuries of any size. I prefer to use it in areas that are difficult to dress, like face and hands. And we start using it in clean, debrided, chronic wounds without bacterial load.
Okay. How about pain management? How do you manage the pain for these patients?
The application itself is not very painful. I think these patients are already suffering, and the debridement prior to applying the dressing is key. If the patient is free of pain after your debridement, you can apply it easily. If the debridement has already been painful and the patient is full of pain, any treatment after that is more or less received as or the patient always say it's painful. But in my experience, if they are free of pain prior to the dressing, then the procedure itself doesn't cause any pain. And with the clean dressing, the need for pain medication is significantly reduced. And you, for example, in children, of course, you reduce the frequency of dressing changes. And that's quite a huge advantage.
Okay, a few last questions. Is it possible to spray antibiotics or analgesics after putting the layer of Spincare on the wound?
I would use it prior to Spincare. You can spray on top of the wound like lidocaine or even topical antibiotics, and then put the dressing on top.
Right.
Did that with our corticosteroid foam or corticosteroid cream. That's a possibility.
And I would just add that in other centers, they have also did vice versa in some cases when they needed some extra cleaning after a few days, they would apply it above the layer. They did not remove it, just apply it above it. Okay, I think, okay, that we have asked this one already. Can we apply for diabetic patients or cancer patient burns?
There's no contraindication for that to my knowledge. I would assume it's the same indication for diabetic or cancer patients. Yeah. There's no influence of the immune system through the dressing itself.
Right. So I think that's about it. Professor Hayek, do you want to add anything or add to the discussion? If you unmute, please. Professor Hayek. Okay, anyhow, I think Professor Hayek is not hearing us. So thank you very much, Professor Plock. We appreciate your time and your efforts and sharing with us your own experience in your hospital. Professor
Thank
Hayek,
you very much. I saw that there are really participants from all over the world. I think we have to mention there are people from Mexico, Brazil, and really all over the world. I'm amazed to have you all here. And it was great talking to you and share our experience. Again, I want to thank everybody for helping to organize this and inviting me. Thanks a lot and have a great evening. Thank you.
Thank you, everyone, for participating and giving us a chance to show the technology.
Thank you. Take care.
Thank you,
Keep safe.
Joseph. Take care.
Bye-bye.
Bye.
Bye.